Thank you very much, and good afternoon, everyone. What I'm going to do is provide you with an update, a brief update on HPTN 065, or what we call Test Link to Care Plus Treat Study, TLC-Plus. This is an ongoing study, and I'll give you just an update on where we're at. As you all know, there's a substantial number of people living with HIV in the United States. And actually, when you look at this global map that shows in different colors the numbers of people living with HIV in various countries around the world, the US is has the seventh largest number of people living with HIV, estimated 1.2 million. So substantial number. Behind, as you in this list, behind countries like South Africa, Nigeria, India, Mozambique, Tanzania, and Zimbabwe. Now, the distribution of HIV/AIDS in the US is not uniform, and we have what we call hotspots. And these hotspots are demonstrated in this map with these circles of varying size based on the number of AIDS cases in the US. And thus, for HPTN 065, we decided to focus in this study on specific communities. And as Deborah Donnell mentioned earlier today, we're focusing on 2 intervention communities in New York, in the Bronx in New York, and Washington, D.C., and then 2 non-intervention communities, which are in Chicago, Miami, Houston, and Philadelphia, as the non-intervention communities. Now, we all realize, and we've heard at this meeting, the importance of what people have called the cascade, what I call the continuum, but essentially that in order to achieve what we want to achieve, in decreasing the numbers of new infections with HIV, we need a multi-component or a combination intervention study or studies. And thus, as we were thinking of designing 065, we thought of the importance of actually including in the study several components or several interventions. Firstly, of course, to increase testing in order to identify HIV-positive individuals, to design an intervention to enhance linkage to care of HIV-positive individuals, to enroll them in HIV care, then to ensure that they initiate antiretroviral therapy in a timely manner, that they adhere to antiretroviral therapy in order to achieve viral suppression, and of course to enhance the adoption of safe sexual behaviors or safe behaviors to decrease transmission. And this figure here includes the components that are actually included in HPTN 065. What was also very important to us is we realized the importance of having different types of interventions, a behavioral intervention, structural interventions, and biomedical intervention. And I'll tell you more about those specific interventions within the various components of the study. So going back to this continuum slide that I showed you yesterday, we also realized that it's not just what the components are, but it's going to be very important to determine the how, what works and what works best. Because it is by optimizing the coverage, optimizing the acceptability, optimizing the effectiveness and the quality that we actually be able to achieve the goals of a combination intervention study. So let me start by describing HPTN 065. So HPTN 065, the purpose of the study is that it is a feasibility study. It's evaluating the feasibility of enhanced community-level HIV testing linked to care plus treat strategy in the US. And the reason we're doing a feasibility study is that we thought that it's absolutely critical to first learn how we can enhance the coverage, how can we enhance the effectiveness, how can we enhance the acceptability, all of these various pieces of the puzzle before we embark on an actual definitive study to look at the impact of such a combination intervention study on HIV incidence. So let's start with the first component of the study. Very important first component is expanding HIV testing, and we've heard a lot of conversations about enhancing HIV testing. And remember, our 2 intervention communities of the Bronx, with about more than 1 million population in the Bronx itself, and Washington, D.C. with about half of that number in terms of the numbers of inhabitants in Washington, D.C. So we focus on 2 components in the context of expanding HIV testing. One is on social mobilization, trying to actually get increase in testing in the most susceptible population in these communities, and these include men who have sex with men, particularly African American men who have sex with men. And the second component is universal offer of testing in emergency department hospital admissions in all of the hospitals in these 2 communities, intervention communities. So let me tell you a bit in very brief about the social mobilization campaign, and that campaign is building on already the efforts that's been ongoing by departments of health in trying to expand testing in these two communities. So we built on what they're doing already by targeting MSM. So the campaign, or this component began November in 2010 in Washington, D.C., and in April in the Bronx in New York. And it's focused on MSM, and the idea is to try to encourage testing of MSM twice a year, as is recommended by the CDC as a very high-risk population. Let me move on to the second component of expanded testing, which is expanded hospital testing. So we have 16 hospitals that are participating in the study, 7 hospitals in Washington, D.C., and 9 hospitals in the Bronx. And we're focusing on 2 areas in these hospitals. And it's really important to keep in mind for me to tell you why we're focusing on universal screen or offer of testing, of course, in an appropriate manner and confidential manner in the emergency department and inpatient admissions. So this is essentially building on the provider-initiated testing principles. And we chose these 2 settings because we knew from other data that testing in these settings has the highest yield. It has the better yield in terms of identifying people who are positive. And since it's very important to identify people who are positive, we focus on trying to expand PICT or provider-initiated testing in the emergency department inpatient admissions. Now, by this I mean not just expanding, but trying to reach universal screen, which is not easy, and I'll tell you what we've been trying to do. So after the second component of the study is HIV testing. From these HIV testing sites, we actually took the participating testing sites, 38 testing sites, and we randomized the sites themselves, not individuals, but the sites, so that some sites are randomized to standard of care, and other sites are randomized to utilizing financial incentive plus standard of care to effect linkage from the testing site to HIV care sites. So at these sites, when they identify somebody who's positive, that individual, depending on whether the site is a standard of care site or a financial incentive site, these individuals would then receive the appropriate intervention. So financial incentives as a structural intervention has been utilized to change for people to adopt certain health behaviors, and it's been quite controversial, actually has been used much more extensively in programs and in studies outside the United States. So it took us quite a while to get comfort level with the community and with the provider community and the patient community in terms of utilizing and evaluating financial incentives and actually deciding also on the amount of the financial incentives based on consultation again with the community and with providers. So this just shows you in a figure, an easy way to see this, the 37 HIV testing sites as part of the study. And so there are 19 in Washington, D.C., and 18 in the Bronx. And some sites have standard of care, and some sites are using financial incentives coupon for people who are identified to be HIV positive. What that means is at a testing site that was randomized or assigned to the financial incentive arm, HIV positive individuals receive a coupon, an individual coupon, and then if they link to HIV care sites and establish care based on certain definitions, essentially two consecutive visits, they receive a gift card, which is the financial incentive. And the goal is then to compare linkage for those individuals who are tested at standard of care sites versus those individuals who were found to be positive at sites that were assigned financial incentives. So after linkage, another component of the study is to look at HIV care sites, again, thinking of that continuum of care. Treatment is initiated at those sites. We are not interfering in terms of the guidelines or when or the threshold for initiation of ART. The sites are essentially to initiate ART per current guidelines based on prevailing guidelines, DHHS guidelines at that point in time. And the goal, of course, is to utilize antiretroviral therapy to achieve and maintain viral suppression. So similar to the linkage component, we have also included in HPTN 065 another site randomized component. And in that component, we call it the viral suppression component. HIV care sites, 39 HIV care sites, participating in the study, 19 in Washington, D.C., and 20 in the Bronx. And again, these sites, not individuals, but the sites themselves, are assigned to either standard of care or provision of financial incentive in the form of a gift card to incentivize individuals who've achieved viral suppression. And the goal is to compare, at the end of the study, to compare again how the sites performed in terms of achievement of viral suppression by whether they were standard of care sites or sites assigned to financial incentives. So as you can see here again in the schema for the study, these are the 39 randomized sites. Again, this is a randomized comparison looking at both the feasibility of financial incentives, but also comparing across the randomized arms, similar to what we're doing up here, the effectiveness of financial incentives. So just to give you a schematic of what could happen or what is happening now, because this study is ongoing, is let's say you have a new patient who's on antiretroviral therapy. The study starts here. The patient is established in care. I don't have time to tell you the definition of this, but the patient has to demonstrate that they're established in care at that particular site, and if that's a financial incentive site, they become eligible for financial incentive gift cards after a certain period of time. If they're virally suppressed, they get a gift card, and essentially, again, the next time they're due for viral load measurements, if again they're suppressed, they get another card, and so on and so forth. We followed the guidelines, the DHS guidelines, that actually indicate that patients should get about 4 viral load measurements maximum a year if all is going well. If you have a current patient, this is not just for new patient, this is for all patients at that site. If you're already a current patient on antiretroviral therapy, again, this is a current patient at the site. The study starts here. They become eligible based on the certain period of time, having been engaged in care at that site. And if they have viral load suppressed, they receive the gift card. If the viral load is not suppressed, they do not receive a gift card until they achieve viral suppression again. And the goal is, at all of the sites, is not just to incentivize people who are already virally suppressed, but to encourage other patients to achieve viral suppression. Now, the 2 key outcomes of the study, as Deborah Ronell mentioned earlier today, are measured through the HIV surveillance system in the US, which is an amazing, robust system. And this gives you, this slide just shows you some of the key data that are collected through the HIV surveillance system in the US, including HIV diagnosis. So we actually can tell by using the surveillance system when a person is diagnosed as HIV positive. And since all CD4 and viral loads are essentially also part of the surveillance systems, it is possible for the Departments of Health and the CDC to determine the linkage and the time to linkage. And again, as the data are by site, we can utilize these data to determine how a specific site, overall a site, has been able to achieve a viral suppression for their population. This shows just the flow of data, and the flow of data goes from the patients themselves, who are followed at a clinical care site, for example, and then goes to the Departments of Health, to the CDC. The data are aggregated, working in partnership with the CDC and Departments of Health, and then are analyzed in collaboration with the HPTN Statistical Center. There's another component of HPTN 065. As I mentioned, there are various biomedical, structural, and also another is a behavioral component, which is what we call the prevention and positives component. And that component is being conducted at a select number of HIV care sites. And at these sites, this is an individual randomized study where individuals, HIV-infected individuals receiving care at specific sites from the 2 communities of Bronx and Washington, D.C., they are randomized. We anticipate about 660 patients are randomized to standard of care for decreasing or adopting safe behaviors versus a Care Plus package of care that I think you heard a little bit about it earlier, that's been adapted for 065. And this is the prevention and positive component, consists of computer-based intervention aimed to assess and change risk behaviors. Anticipate 1,320 patients to be recruited. As I mentioned, about 600 from each of the communities, from 6 sites in the Bronx and 6 sites in Washington, D.C. And this component of the study, Ann Kurth, is leading this part. Now, I'll just focus on one component and try to demonstrate to you the complexities entailed in achieving some of the goals of the study. So let's focus on what we're trying to do, for example, with the effort towards achieving universal provider-initiated hospital-based testing. As you can imagine, very large numbers of individuals go through emergency departments in these two very, very busy metropolitan areas, and also large numbers of people are admitted, and we're focusing on the whole hospital, not just medicine or surgery, everyone who's admitted to the hospital and everyone who touches the emergency department. So lots of dimensions to think about. There's the dimension of the provider level. Issues about provider acceptability and provider enthusiasm, provider resistance, and others. There's also the systems level issues in terms of availability of certain numbers of staff, whether they're available during the day, during the night, computer systems, availability of testing materials, where the tests are being done, how the results are coming back, who's paying for the test, and I could go on and on and on. And then there are patient level issues, which I think are actually sometimes not as insurmountable as some of the provider and systems level issues. So what we've been trying to do is to build on some of the initiatives that are going on in the US, and particularly in New York and Washington. For example, both communities now are supporting opt-out testing. I have to remind you that actually the CDC has had guidelines in place for several years that supported that all individuals who essentially visit a health facility should be offered an HIV test. So we've had this in place. But nonetheless, it has not really adopted broadly or operationalized. So the good news is that opt-out testing is now supported by both the Bronx in New York State and in Washington, D.C. We've made suggestions, for example, of combining consent forms to include HIV. We've also suggested, and some of the hospitals have tried to adopt standing orders for testing on admission and having HIV testing being linked to when you have your blood drawn, reviewing admission records for testing, again, to make sure that people have been approached for testing, and then using incentive programs for different kinds of, as was demonstrated, I think, in China, to try to incentivize the staff either to reward ED shifts or inpatient services or wards that are doing better than others. And lastly, our effort have also focused on using conventional lab testing rather than what's really prevalent often in many of these settings, which is the point-of-care rapid testing. So one important part of our effort has been trying to move people away from point-of-care rapid testing, which is very intensive, requires counselors and so on, to what we're calling these multi-platform analyzers or random access technology, which is available now, which is a rapid test that can be done in the laboratory. And this means that it can be done at high speed, can be done at high volume, and the results can come back to the individual within an hour. So it can be done for emergency department visits and certainly for inpatient setting. And it's not a very large capital investment. It's not necessary because in many hospitals, this equipment is already available. It not only is used for HIV, it's used for many, many other tests as well in these hospitals. And also the important thing is the result then interacts with the lab information systems rather than having results on small pieces of paper. This sort of fits in with the information system at many of these large institutions. The other thing that's very exciting about these new tests is that while the traditional rapid point-of-care testing, that essentially, if you look at Western blot positive at this point in time, and these are some of the rapid point-of-care testing, some of the new tests actually identify HIV infection much earlier. So they offer a tremendous potential, particularly in the emergency department, in identifying people earlier in HIV infection. So we've been working very hard with the hospitals to try to convince laboratorians as well as the people who are doing the testing at these institutions that this could be incorporated in their system, and they'd be able to identify people earlier in HIV infection and be able to obviously test much larger numbers of individuals with fewer staff members. And this is what it looks like essentially. These machines they do lots of other tests, and they can also do HIV testing, and the results are available within half an hour or so. And many of these of the tests of the labs have these equipment already in place. So another, just from the implementation perspective of how we're monitoring this component of the study, we need to track the progress. And there are many, many different, if you look here, this is not real data, but these are the kind of data we're following by the hospitals here, numbered at the bottom. But we've been trying to track whether they've had standing orders established, whether they've modified their consent for, whether they have prompts in their electronic medical system, whether they have billing and reimbursement taken care of, whether they have IT support, staff buy-in, laboratory buy-in, and so on and so forth. So as we go from month to month and quarter to quarter, we're trying to follow the implementation of at least this one component of the study. But I think this demonstrates again that the complexity of trying to change behaviors and trying to change routines if we're really going to try to expand the whole concept of combination interventions and the whole concept of testing and treating. There are two other components of this study. Very important is to identify also and to measure providers and their own attitudes, as well as knowledge and attitudes regarding use of antiretroviral therapy for treatment as well as for prevention. So there's a provider survey that's administered twice, once at the beginning of the study, and the results of the baseline provider survey is a poster here at this meeting. And this measures, this is done, completed online, measures antiretroviral attitudes about knowledge, attitudes in the use of antiretroviral therapy. Who would they use antiretroviral therapy in? Who would they not use in? What are some of the factors they utilize in making a judgment as to who's ready for initiation of antiretroviral therapy? And then also we're measuring their attitudes regarding the use of financial incentives for linkage to care and viral suppression, because it's going to be very important to learn how the provider feel about these things if we want to expand this beyond this study. As I mentioned, the provider survey baseline has been completed, and we're going to be repeating this at the end of the study to see what's happened over time. This was done before the results of 052, and it'll be interesting to see what happens at the end of the study in terms of provider. We're also doing patient surveys as well, which will be administered again at the beginning of the study at baseline, as well as at the end of the study. And it's measuring similar things along the lines of antiretroviral use for both, from the patient's perspective now, in terms of use for treatment for individual benefit and for prevention purposes. And we're also trying to understand a bit about the patient's perspectives on financial incentives, because that's also going to be very important information. And the patient surveys are incorporated into the tablets on which we're administering the prevention for positive component of the study. So this is in summary the various components of the study, the testing and linkage to care, as I mentioned, with the components of the testing, with the site randomized components for linkage, the HIV treatment component with site randomization for, again, for financial incentives, and the prevention and positive, which is an individual randomized component, again, looking to compare Care Plus versus standard of care. So in conclusion, as you all know, we have very compelling evidence in support of the use of antiretroviral therapy for prevention of transmission discord in couples, but really the effectiveness on a population level remains unknown. And this study, HPTN 065 or TLC-Plus, is a community-focused study that's aiming to determine the feasibility and to really dig down and try to understand what's going to make it possible. How can we optimize every part of the cascade in terms of coverage, acceptability, effectiveness, so we can, in the end, design the ultimate definitive study to demonstrate whether all of this can have an impact on HIV incidence. The study includes several innovations, I believe. It includes multiple components, an observational component. For example, the expansion of HIV testing is observational. A site randomized component, that's the financial incentives for linkage and the financial incentives for viral suppression. The sites are randomized. And also an individual randomized component, as I mentioned, the prevention for positives component. It involves a behavioral, a biomedical, and structural interventions. It includes both feasibility and effectiveness outcomes. And I think very importantly, and it's really one of the first studies that's utilizing HIV surveillance data to determine key study outcomes. There is an incredible resource in the US in terms of the surveillance data, and this is a study that's hopefully going to lay the foundation for utilizing this very rich surveillance system that's managed by the CDC in order to answer some very important research questions. It also involves a very strong collaboration with departments of health and with the CDC, really a wonderful collaboration. Without their true engagement every step of the way, this would not have been possible. And also it's conducted in collaboration with several testing and care sites in the communities. These are not research sites. This is truly also something that's unique about the study. It's really working with the sites, these are care sites and testing sites, and many of them have never really done research before. So it's breaking new grounds in terms of expanding the potential for doing community-focused research in the US. And of course, I mentioned lastly, it builds on public health interventions of the work that's being done in these same communities, sort of enhancing what's already been happening. And we hope that the findings from the study will help inform the path towards a definitive study of ART for prevention in combination with many other interventions. As I always say, ART for prevention is a combination intervention in the US and globally. I want to end by acknowledging Bernie Branson, who is the study co-chair and a remarkable partner in this effort. He is at the Division of HIV/AIDS Prevention at the CDC in Atlanta, the 065 study team, and we have a wonderful community advisory group that's been working with us hand in hand to try to build the buy-in and the support for the study that's breaking new grounds in many ways. The departments of health in the intervention and non-intervention communities, and of course the participating HIV testing and care sites in the Bronx and Washington. And this study is also uniquely supported by NIAID, NIMH, as well as by the CDC. I thank them all for their support. Looking forward to sharing with you, hopefully, the results of this ongoing study in the future. Thank you.